Cancer After Transplant 101. So I'm going to give you some of the basics of transplant and cancer related issues after transplant. All right, so a disclosure, I am a consultant for Pearl Diagnostics, but that has not impacted any of the information that I will be sharing with you today. So the objectives for today's talk are to understand the role of immunosuppression in cancer, describe the role of viruses in cancer, explain the role of voriconazole and skin cancer, discuss the most common cancers after transplant. So let's jump right in. So let's go into some of the background here. So in the US, there's nearly 40,000 transplants done per year as of 2020, and that's according to UNOS data. Kidneys are done the most, then livers, and then heart and lungs. Organ transplant survival rates are approximately 90% at 1 year and 75% at 5 years. This survival rate is largely attributable to the potent immunosuppressive drugs that we use to prevent rejection. So there is a 2 to 3-fold increased risk of developing cancer when compared with the general population. There is a 20% cancer incidence after 10 years of immunosuppression. And there are 3 categories of cancers that can occur after transplant. The first one is called de novo, and this means anew. So these are cancers that start on their own and usually away from the transplanted organ. Then there's donor-related. This is rare, but does happen. And this is when cancer cells are transmitted from the donor inadvertently, or when cancer arises from within the transplanted organ itself. And then there's recurrent cancers. So these are pre-transplant cancers that were addressed and then unfortunately recur after transplant. So let's talk about immunosuppression, because as I mentioned, immunosuppression after several years of it can increase your risk for developing a cancer. So with immunosuppression, there are undesirable side effects. Some of them are directly drug related, and that include things like high blood pressure, diabetes, developing kidney dysfunction, or high cholesterol. And then there's other kind of drug related, but more indirectly drug related side effects, and those include infections and cancer. So long-term suppression plays a role in all 3 categories of those cancers that we just discussed. So the de novo, the recurrent, and the ones that just arise from the donor themselves. Immunosuppression is a principal factor that increases risk for post-transplant cancer. And it's ultimately the total dose, duration, and intensity of the drug regimens used that influences the risk of cancer development. So episodes of rejection, especially in the first year of transplant, increases the likelihood of developing a secondary cancer because of the greater level of immunosuppression needed to treat the rejection. So there was a study of over 50,000 kidney and heart transplant recipients from centers in Europe and North America. And the incidence of PTLD, which we will talk about later, which is a type of non-Hodgkin lymphoma, was the highest in the first year of transplant. And then that risk fell by 80% thereafter. The incidence was greater in heart versus kidney recipients. And this is reflective of the fact that there is a need for a greater degree of immunosuppression in heart transplant recipients than what you need in kidney transplant recipients. So this study essentially showed that immunosuppression and the amount of immunosuppression needed to prevent rejection is directly correlated with the development of cancer. But that cancer risk for, in particular, PTLD was highest in the first year, and then it declined after that. So the type of immunosuppression also impacts your risk of developing cancer. So these are just a few drugs that are commonly used: cyclosporin, tacrolimus, azathioprine, and sirolimus. And all of these ultimately develop the propensity to have abnormal cell growth and leading to cancer. So they all work slightly differently in their mechanism of action, but the end result ultimately is the same. The one immunosuppressive drug, mycophenolate mofetil, or also known as Cellcept, actually for this drug, studies suggest that the risk of developing cancer is not higher with this drug, and actually it may in fact be associated with a decreased risk of cancer. And that is because, again, as this drug has a different mechanism of action, it does not necessarily lead to that abnormal cell growth that we see with the other drugs. So let's move on to talking about immunosuppression and viral infections, and you will see why this is important in just a few moments. So when you have immunosuppression on board, that increases your susceptibility to viral infections. To address that, you have to then decrease immunosuppression and possibly add on an antiviral medication. There are two potential outcomes with this. One, you can achieve viral control where the viral infection is under control, or you fail to achieve viral control. And when you have viruses that are out of control in your body, this actually leads to further immunosuppressive effects from the viral growth itself. The virus functions to suppress your immune system in order to evade your immune system and have the upper hand in causing infection. So it's kind of a catch-22. You have immunosuppression on board, but then that leads to an increased risk of viral infections. And if you can't achieve control of that viral infection, then the virus itself can also further cause immunosuppression. So this picture as a whole, based on what we've talked about immunosuppression, can kind of set you up a little bit to understand how, well, if you have a lot of immunosuppression on board from drugs and or from viruses, your chances of developing a cancer increases a little bit further. So viruses are important on their own, actually, not in relation to immunosuppression, but just as themselves. There are actually viruses that can lead to cancer. So these are called oncogenic viruses. So these are viruses, as I said, that have the potential to cause cancer. So what are some examples? So there's Epstein-Barr virus, or this is also the virus that causes mono. We have human herpes virus type 8, which is a viral infection that is predominantly seen amongst immunocompromised individuals, but that illness presentation, when you first identify that person as having that virus, it's often as a cancer. Then there's human T lymphocyte virus type 1, which causes illness in only about 5% of those infected. So many people are infected, but only 5% will actually have illness associated with this virus. But one of the illness presentations associated with this virus is cancer. And then human papilloma virus. Some of you may have heard about this. There is a vaccine available for this for younger individuals, but this tends to cause warts. We often see it on children's hands, feet, sometimes in the genital regions. But this particular virus is implicated in many, many cancers that we see today, including skin cancer, head and neck cancer, cervical cancer, anal cancer, and that's just to name a few. So how do we acquire these oncogenic viruses? So one way is there's reactivation of latent virus in the body. And a good example of this is actually the Epstein-Barr virus or monovirus. Just about every adult has had exposure to Epstein-Barr virus. There is a very small percentage of people who do not or have not ever been exposed to this virus. But what happens is after you experience the initial illness, which is usually mono from this virus, it then lays dormant, sleeping in our bodies, and stays quiet for essentially the rest of our lives until something else comes along and causes immune suppression. And that often here in this case could be a transplant. So if you receive a transplanted organ, we then have to suppress your immune system to prevent rejection of that organ. But when we suppress that immune system, that gives this Epstein-Barr virus an opportunity to wake up and become active again. And so we call that reactivation of a latent virus. So that's one way that Epstein-Barr virus becomes active and becomes part of the picture after transplant. We can also acquire it from the donor. And when we talk about Epstein-Barr virus again later on in this talk, I'll explain that a little bit further. And then you can also acquire it from the community or the environment. And that's the case as with like human papilloma virus. So that is something that you can acquire by exposure to other people who potentially have several warts on their hands, and you touch their hand, you are at risk for having picked up that virus in that instance. So oncogenic viruses, as I stated on a couple slides ago, can contribute to an overall state of immunosuppression if they are active. And they also play a role in causing abnormal growth of cells, ultimately leading to cancer. So viruses that can cause cancer after transplant, there's about a 5-fold or greater increase in transplant recipients to develop tumors associated with viruses. So that includes Kaposi sarcoma, which is a type of non-melanoma skin cancer. We'll talk about that briefly later on. There's also other non-melanoma skin cancers that are viral associated, non-Hodgkin's lymphoma, or also PTLD, which we'll again talk about later, liver cancer, and anal cancer, vaginal or vulva cancer, and then cancer involving the lip is also oftentimes viral associated. So again, these cancers or malignancies are all associated with viral infections. So what are some common cancers that we tend to see after transplant? So we tend to see non-melanoma skin cancers, post-transplant lymphoproliferative disorder, or PTLD, which is what we've kind of talked about briefly already, but we'll get into further detail later on, and anogenital cancers, or anal and genital cancers. These cancers tend to be de novo. So these tend to be ones that arise on their own, usually away from the transplanted organ. Then we have melanoma skin cancers, renal cell carcinoma, which is a type of kidney cancer, hepatocellular carcinoma, which is a type of liver cancer. So these last three can be either donor-derived, so coming from the donor themselves, or recurrent, so something that happened pre-transplant but then occurs again after transplant. Melanoma is actually listed in purple because it can actually be any of these. It can be de novo, donor-derived, or recurrent. So let's jump right into skin cancers. So when we talk about skin cancers as a whole, we're referring to both non-melanoma and melanoma skin cancers. So in adult transplant recipients, skin cancers in general account for almost 40% of cancers in organ transplant recipients. And they develop in more than 50% of white organ transplant recipients and in approximately 6% of non-white patients. And in pediatric recipients, skin cancers account for about 13 to 55% of all post-transplant cancers. So it's rather common amongst pediatric patients as well. So let's go into non-melanoma skin cancers. So this is the most common post-transplant cancer, and this usually comprises of squamous cell cancer, basal cell cancer, Kaposi sarcoma, and Merkel cell cancer. I will go into the first three. I'm not going to touch upon Merkel cell because it is actually the rarest of this most common cancer. So it's not seen as often as the other ones are. This is again a type of de novo cancer, or cancer arising on its own, and it occurs in more than 50% of all transplant recipients. And immunosuppressive drugs, not only do they do what we talked about before, where they lead to the abnormal growth of cells, they also enhance the damaging effects of UV rays. So it further exacerbates the damages that UV rays cause on our skin, making us more susceptible to skin cancers. Oops. And viral infections can play a role, as we briefly touched upon, and antifungals can play a role, which I will get into in just a bit. So squamous cell cancer is the most common subtype of non-melanoma skin cancer seen. Compared to the general population, transplant patients are about 65 to 250 times more likely to develop squamous cell cancers. And this is a broad range, but it's kind of a range that has been seen amongst all different types of studies out there on this particular type of cancer in transplant recipients. Basal cell cancer is the second most common subtype. And compared to the general population, transplant patients are about 6 to 16 times more likely to develop basal cell cancer. Together, they account for more than 90% of the non-melanoma skin cancer seen. And again, these are much less common in non-white transplant patients as opposed to white transplant patients. And that has to do with the fair skin and the lack of melanin or lack of pigmentation in the skin cells, which leads you to be more susceptible to the UV rays. And again, as I just mentioned, fair skin and UV exposures increases that risk of developing skin cancers. The remainder, the other 10% that I've talked that are not squamous cell and basal cell cancers, are often due to Merkel cell and Kaposi sarcoma, with Merkel cell being a smaller share of that 10%. So let's briefly talk about viruses and non-melanoma skin cancer. So human herpes virus type 8 can result in a subtype called Kaposi sarcoma. Human papillomaviruses, or HPV, can be associated with squamous cell cancer. So as I mentioned a little while ago, human papillomaviruses are often the cause of warts, but they are also found in about 90% of squamous cell cancers in transplant recipients. And this is as compared to about 11 to 32% of non-transplant patients. So only about a third of non-transplant patients who develop squamous cell cancers of the skin are associated with human papillomavirus, as opposed to about 90% of those of transplant recipients who develop squamous cell cancer. It's usually human papillomavirus in those instances. So 30% of 50% of the patients with squamous cell cancer also develop basal cell cancer. 80% of squamous cell cancers occur on the back of your hands and forearms in those who are less than 40 years old. And 80% of the squamous cell cancers develop on your head and neck if you're greater than 40 years old. And that just has to do with skin exposure over time. What areas tend to be more exposed over time, vice other areas. And then squamous cell cancer is usually aggressive when it occurs after transplant. So it requires aggressive therapies and measures to treat and prevent going down the road. It is most often diagnosed clinically, and this highlights the importance of routine skin exams. So seeing a dermatologist periodically and regularly is going to be crucial for identifying skin findings that may be abnormal and undergoing biopsy to determine what it is and implementing therapies sooner rather than later. So seeing that dermatologist regularly is going to be very, very important. So let's go into voriconazole and skin cancer. So some of you may know what voriconazole is and some may not, and I will explain to you what it is. So voriconazole, also called VFEND, is a type of antifungal drug used to treat mold infections, including Aspergillus infections. Aspergillus is actually an important cause of infection-related morbidity and mortality amongst transplant recipients. And we tend to see Aspergillus infections the most in lung transplant recipients. So voriconazole, this drug, is commonly used more so amongst lung transplant recipients than any other transplant group out there. And a side effect from this drug is photosensitivity. In other words, it makes your skin ultra sensitive to the UV rays that are out there. And that often results in sunburns on sun exposed areas. Sunburned skin is more susceptible or more likely to develop skin cancers as opposed to areas of the skin that have not been sunburned. So it is very essential to wear sunscreen or to use sun protective clothing when you're on this drug. But in general, as a transplant recipient, those should be measures that you take regularly. But when you're on this drug in particular, it's even more essential that you do this. So it has actually been linked with the development of aggressive squamous cell cancers in transplant recipients. And it's postulated that it's the voriconazole-induced photosensitivity along with the use of immunosuppression that ultimately increases the risk for skin cancer. So as I just mentioned, it highlights the importance of sunscreen all the time, but even more so when taking this drug. So let's briefly talk about Kaposi sarcoma. So it's associated with human herpes virus 8, and it usually occurs in those of Mediterranean, Jewish, Arabic, Caribbean, or African descent. And it usually develops quickly after transplantation, and it's tended to be seen amongst men more so than women. Let's go into melanoma now. So what we just talked about were the non-melanoma skin cancers, and we're going to shift to the melanoma skin cancers. So there is a 3 to 5-fold increased risk for melanoma in transplant recipients. And risk factors for developing melanoma include the presence of moles, fair skin, being male, your age, if you have a kidney transplant versus liver or lung, which kidney transplants tend to be of greater risk, and then if you tend to use azathioprine immunosuppression. And then again, melanoma can fall into all 3 clinical scenarios. It can be a de novo cancer, a donor-derived cancer, or a recurrent cancer. So the most common location of melanoma occurrence tends to be on your trunk, your upper limbs, or your head and neck. And it's actually more commonly seen in pediatric transplant recipients with an incidence of about 12% versus the incidence in adult transplant recipients, which is 5%. So again, routine skin examinations are going to be crucial here. So let's move away from skin cancers and talk about post-transplant lymphoproliferative disorder, or PTLD. I know I've kind of mentioned this periodically throughout the talk thus far, but now we're going to jump right in and kind of go into more detail about what this is. So post-transplant lymphoproliferative disorder, or PTLD, is a spectrum of lymphoproliferative disorders, which basically refers to the abnormal growth of cells of the lymphatic system. So you can see here in this picture, everything that is seen on this diagram is part of your lymphatic system. So your tonsils, your lymph nodes, which are all the dots that you see throughout this image, these are all areas where you can have lymph nodes enlarge due to abnormal growth. So you can have them in your neck, your groin, behind your knees, near your elbows, all around your stomach. Your spleen is part of the lymphatic system, and the purpose of your lymphatic system is to help clear infection. So I'll talk about this in just a moment. So your lymphatic system is made up of white blood cells. And there are 2 types of lymphatic cells that are primarily involved in post-transplant lymphoproliferative disorders, or PTLD. T cells and B cells. Those are the 2 types of white blood cells that we're going to be focusing on. So B cells, as according to this picture, attacks invaders or infectious pathogens outside of the cells, versus T cells, where they attack those pathogens or those invaders inside the cells. 85 to 90% of PTLD actually arises from the B cells, and the rest arises in the T cells. So the risk for PTLD is greatest in the first year post-transplant. More than 80% of PTLD cases occur in the first year after transplant, and it's more commonly seen in pediatric recipients or even younger adult recipients. And it's the second most common cancer in adult recipients after the skin cancers, and accounts for about 20% of all cancers in transplant recipients. Risk factors for developing this include some genetics, your degree of immunosuppression, your age, the type of transplanted organ you have, and viral infections. So let's go into this a little bit further. So about your age, so if you're less than 10 or greater than 60, those seem to be the highest risk age groups. When you have your transplant in those age groups, you tend to be at highest risk for developing PTLD. The type of transplanted organ also plays a role. So if you've had an intestinal transplant or a small bowel transplant in particular, your risk is about 20%. If you've had a heart or lung or both transplanted, your risk is about 2 to 10%. And if you've had liver and or kidney transplants, your risk is about 1 to 5%. So let's go into PTLD and viruses. So the Epstein-Barr virus, or that monovirus we talked about earlier, is the most commonly associated viral infection with PTLD. 60 to 70% of B cell PTLDs are actually associated with EBV infection. And 10 to 40% of the T cell PTLDs are associated with EBV. So the increased risk of PTLD, there's an increased risk of PTLD among EBV negative recipients from EBV positive donors. So in other words, we check everybody's EBV status prior to undergoing a transplant. And we check the donor's EBV status, whether or not it's a deceased or living donor, we check that status prior to transplantation. So going into transplant, your transplant physician knows if you are an EBV negative recipient, meaning you've never been exposed to EBV, and if you are receiving an EBV positive donor organ. In other words, that your donor was exposed to EBV and essentially has that living in its cells. As I mentioned earlier, EBV lays dormant. Where does it lay dormant? It lays dormant in all of our cells and all of our body. So any transplanted organ from an EBV positive donor will contain EBV when it's put into a recipient. Now, what matters is if your recipient is negative or positive for EBV. If negative, you are at the highest risk of developing PTLD. So as stated here, the incidence of PTLD for an EBV negative recipient from an EBV positive donor is 24 times higher than that for an EBV positive recipient. So you're at a much greater risk of developing PTLD that is EBV associated if you are an EBV negative recipient receiving an EBV positive donor organ. So how do we diagnose PTLD? So the disease presentation is often nonspecific. You can have fevers, weight loss, fatigue. You can have enlarged lymph nodes, and then you can develop symptoms associated to compression of surrounding organs due to a development of a mass in your body. And this nonspecific presentation is what often delays diagnosis, unfortunately. Diagnosis is often made with imaging and biopsy, and it usually presents as a new mass on imaging or multiply enlarged lymph nodes. So all the lymph nodes in your neck, for example, or all the lymph nodes in your chest, for example. So, or we see just a new mass. In either scenario, we will biopsy either a lymph node or the mass itself to make the diagnosis and then implement therapies accordingly. PTLD may actually involve the transplanted organ in about 50% of the cases. So if you get a kidney transplant and you develop PTLD, there's a 50% chance that it may actually involve the kidney itself. And it can be detected early by monitoring EBV levels. So EBV monitoring. So any person who is an EBV negative recipient who gets an EBV positive donated organ will be placed on an EBV monitoring protocol at their transplant center. This is standard across all transplant centers. And that EBV monitoring will essentially entail a blood test. And it can help reveal PTLD onset early on. So in this graph, you can see here that the onset of iatrogenic immunosuppression is essentially at the time of transplantation. So that's when you get your immune suppression. And you will then develop blips of higher levels of EBV after immunosuppression, and that is actually quite normal. But it's when we see this steady rise. These lines here, the red and the blue, are representative of the levels of EBV in your blood. So when you see this steady rise, that's when you start to worry about PTLD. Now, when you begin to see this steady rise, you can try and prevent PTLD from occurring by backing off on immunosuppression safely, by checking EBV levels a little bit more frequently to see what's going on. But sometimes, despite those best efforts, it will progress. And it's not until you reach a higher level of EBV in your blood that you then begin to have symptoms. But that's usually when PTLD has already set in. And then once you implement successful therapy, the levels of EBV will decline in your blood and you will go back to having these usual little blips, which are just slight increases in the level, then it declines, then a little increase and it declines, and that's completely normal. It's, again, the steady increase that we don't like to see. So then when we identify PTLD, what is the treatment? So as I mentioned, reduction of immunosuppression is really crucial for PTLD treatment. So we have to do this safely, and it's a very fine balancing act between reducing immunosuppression to achieve viral control, but also reducing immunosuppression to a level where we can still safely prevent rejection. Then we also begin chemotherapy. And if a viral cause is proven, which most cases EBV is the viral proven cause, then we implement antiviral therapies as well. And then sometimes if you have a large mass, we will also implement radiation therapy to try and shrink the size of that mass. Despite these treatments, mortality is generally 30 to 60%. So PTLD is not a favorable diagnosis to have, but that does not mean that it's not curable. It certainly is curable. So the takeaway from PTLD is to know that it's important to seek medical care when things just don't feel quite right. And I think everyone out there probably knows what I mean. When you just know something's off and you can't really put your finger on it, seek medical attention and advocate for yourself. Get to an answer, get to the bottom of things. If you're not satisfied with the answer you're getting, continue to ask questions of your transplant physician, because there is the possibility that maybe something's going on and that it's deeper below the surface than we're able to identify with a routine physical exam, and you may need further imaging or something to be able to identify the exact cause of why things just don't feel right. So let's move on to anogenital cancers. So these are cancers involving the anogenital region, so the anus, the vulva, the perianal region, penis, scrotum, or perineum. And this accounts for only about 2 to 3% of cancers in transplant recipients, and is generally caused by a virus, the human papilloma virus. The incidence of HPV-associated anogenital cancers is 100 times greater in transplant recipients than the general population. And there tends to be a female predominance. For every one man diagnosed with this, there are 2 women diagnosed with it. HPV positive kidney transplant recipient, for example, will have a 14-fold increased risk for cervical cancer if you are a woman, a 50-fold increased risk for vulvar or vaginal cancer if you are a woman, and a 100-fold increased risk for anal cancer regardless of gender. This is usually diagnosed clinically. So again, this is the need for routine evaluation of the anogenital regions. So if you're a woman undergoing gynecologic evaluations with pap smears regularly is going to be crucial. Examining the anal area is also going to be important. And there are actually anal pap smears out there that can be done, and that are often done in people who are at high risk for developing this. So for example, transplant recipients. So it is something that exists and is out there, but if you have no history of having had warts or having had an abnormal pap smear, then the chances of these are a little bit less, but not by much. So it's still important that these areas get examined routinely. And visual inspection of the anal area is also sufficient for identifying if there are abnormal growths such as warts or things of that nature. And then to evaluate for anogenital cancers or anal cancers in particular that happen internally, it's going to be part of your routine colonoscopies. So you should definitely undergo routine colonoscopy as needed according to your transplant physician's guidance. And I say as needed because oftentimes there are other factors that play into when you initiate that screening and how often you get that screening, and only your transplant provider and you would be able to make that decision together. So let's move on to cancers due to pre-existing conditions. So this is what we were talking about, the recurrent cancers, the cancers that happened pre-transplant and unfortunately recur after transplant. So hepatocellular cancer, which is liver cancer, cholangiocarcinoma, which is gallbladder cancer, and colon cancer are all cancers that we tend to see recurring after transplant if they occurred pre-transplant. So hepatocellular cancer may recur after a liver transplant in 3.5 to 21% of cases. And then if you have primary sclerosing cholangitis with associated ulcerative colitis, these are autoimmune conditions. If you have these, you are actually at an increased risk of cholangiocarcinoma or gallbladder cancer, as well as colon cancer. So it's not so much that you had those cancers beforehand, but if you were transplanted for primary sclerosing cholangitis with associated ulcerative colitis, then you have an increased risk of those cancers going into transplant. Renal cell cancer or kidney cancer has an increased incidence in kidney, liver, and heart transplant recipients. Generally, these are small cancers with low aggressive potential, and so prognosis is usually good with surgical removal. Unfortunately, if it is kidney cancer involving the transplanted kidney, it may entail needing to remove that transplanted kidney altogether. Oftentimes, if it's involving your native kidneys or the kidneys you were born with, it will also entail oftentimes removing that entire kidney. So if it involves a kidney that's been transplanted, it's a little bit more impactful because then you ultimately have to remove a kidney that was potentially functional versus a native kidney, which are no longer being used if you are a kidney transplant recipient. If you're a liver and heart transplant recipient, you can safely remove one kidney and still have one kidney functional in the body. So let's move on and steer away a little bit from the cancers that occur after transplant to how can we screen for these cancers and prevent them. So the ability to prevent and detect cancers in the transplant patient relies upon periodic screening examinations and strict adherence to preventative measures. So that includes routine evaluations by your physician, undergoing pap smears if you're a woman, undergoing colonoscopies, but also adherence to preventative measures. So that includes things like sunscreen and sun protective clothing when you're out in the sun for prolonged periods of time. Those are all measures that we need to take to help detect and prevent cancers. So as alluded to, age-appropriate screening, for example, colonoscopies, are done more frequently in transplant recipients than the general population, but only you and your transplant provider, as I stated before, can decide the frequency and the time at which you need to begin doing those screenings. Skin cancer, liver cancer, and anogenital cancer all fall into this category of things that need to be done probably more frequently than the general population, but you need to come to that decision with your provider. And then avoidance of excessive immunosuppression. Now, this isn't really up to you, but this is up to your physician. So as time goes on, many times we start to back off on immunosuppression. The more stable you are and the less rejection episodes you've had, the more likely you are to back off on immunosuppression. And it's to try and avoid that total dose duration and intensity of immunosuppression that I talked about earlier that often leads to cancer. So if you've had rejection episodes, though, unfortunately, the amount of immunosuppression you need will be higher. And so it's kind of an unavoidable evil, but when it's possible to back off on immunosuppression, we will do so. And then, as I stated previously, sun protective measures. So avoiding sun during peak hours, wearing sunscreen and SPF 50 or greater, and then sun protective clothing, so UV clothing, will be all helpful in protecting your skin against developing skin cancers. And then vaccination against human papillomavirus is also another measure we can take. So that's all based on age. It's generally for women, I believe, ages 9 to 26, and for men, ages 11 to 26. So it is important that if you are a younger transplant recipient and are able to receive the HPV vaccine, that you do so. There are other vaccination against other viruses to include hepatitis B, which can predispose you to hepatocellular carcinoma or liver cancer. And so every transplant recipient is generally vaccinated against hepatitis B as well. And that's for that reason. And then, of course, antiviral use and blood monitoring in those who are EBV negative and receive an EBV positive organ or organs. So in summary, the take-home points are: immunosuppression plays a role in the development of cancers and in developing infections that can increase your risk for developing cancers. So the total dose, duration, and intensity of drug regimens ultimately influences the risk of cancer development. Cancers can develop on their own. They can develop from the donated organ, or they can be recurrent of pre-transplant cancers. Oncogenic viruses can play a role in developing cancers. And most encountered cancers after transplant include skin cancers, so melanoma and non-melanoma, PTLD, renal cell cancer, hepatocellular cancer, and anogenital cancers. And it's postulated that voriconazole, the antifungal drug, can play a role in the development of skin cancer. Sunscreen and sun protective clothing is necessary on all exposed areas as a preventative measure against skin cancers. And routine doctor's examinations and performing surveillance for cancer development is vital to prevention. Ultimately, you know your body, so when something doesn't seem right, speak up and advocate for yourself. These were the references for this talk, and I am happy to take questions. Oh, I think you're muted.
In myself. I hit it, but I guess I didn't hit it right. So thank you for letting me know. Thank you, Dr. Seema. It's a lot of information. And I am just so glad that I never had to learn how to say all of those words, because I don't think I would have done quite a good job. Well, we do have some questions. And let's see, let's go back to the beginning. So we got a hi from Boynton Beach in Florida. Hello, Joel and Judy. And can immunosuppressed transplant patients ever clear HPV? I was never HPV plus until 6 years after transplant, but I've had 2 colonoscopies in the last year and I'm still coming up HPV plus. Am I stuck with this for life?
So that's a really good question. So in people who are not immunosuppressed, there is the potential to clear HPV with your own immune system. It happens, but it's not something that happens as often in immunosuppressed individuals. So unfortunately, if you've been repeatedly positive, it's quite possible that your immune system is just too suppressed with the medicines that you're receiving to be able to clear this particular virus. So I don't want to say you're stuck with it for life, but there's a good chance you may be.
Thank you. Is CMV cancer causing virus? My donor had it. I do not. Taking letermovir for prevention. I probably said that wrong.
So no, letermovir. Yep. So CMV, thankfully, is actually not oncogenic, so it's not cancer causing that we are aware of. So in all the patients that I have seen with CMV who often do need letermovir for prevention, I've never seen a cancer develop in them from the CMV itself. So I think you're probably okay with the CMV. It's primarily EBV that we worry about. And we, just like EBV, and we also check your serostatus, or whether or not you're positive or negative for CMV, and if your donor is positive or negative for CMV. And similar to EBV, we also monitor your CMV, as I'm sure you're on a monitoring protocol of some sort. So, but I don't think you need to worry about cancers from CMV itself.
Thank you. Stan made a comment about not recalling much emphasis on getting information on increased skin cancer risks during pre-transplant counseling. So, you know, he's, I think, thankful for this information. Jessica mentioned so many acronyms. What blood test is done for EBV?
So it's just a blood test that checks the viral level in your blood. So it's literally when you go in to get your blood levels done for your immunosuppression, like for example, for tacrolimus, or when you go in to just get routine blood work for your transplant physician, if you are in that group that needs EBV monitoring, it will just be one more tube that they take at that time, and they check for EBV virus levels in the blood. So it's really simple. There's really nothing extra on your part other than a little bit more blood, and it's just a separate test that we run. The big thing with the EBV virus testing is that it's a level that we can quantify. So there are 2 types of tests out there: a quantifiable level and what we call a qualitative level. So qualitative just simply says detected, not detected. Quantifiable levels tell us an actual value. It'll tell you 500 versus 5,000 versus 50,000. And that's the value we need to know, a quantifiable value, an actual number. So when you're getting your reports, if you're seeing an EBV test being done and it's simply saying detected or not detected, it could be an error on the order that was placed. So go back to your transplant physician and make sure that they're aware that that test result was only a detected, not detected, and that you want a quantifiable level, because I think that will be more telling for your transplant physician on how to best proceed with your care if you are on an EBV monitoring protocol.
Thank you. Can you shed some light on PTLD, for example, percentage of kidney transplant recipients that might get it, the survival rate, cure rate, and is mortality 30 to 60% at 5 years or some longer period?
So can you go back to the first question? I'm sorry, the first question in that string.
Can you shed more light on PTLD, percentage of kidney transplant recipients that might get it, survival rate, cure rate, and is mortality of 30 to 60%? There's another part of the question down a little further. Is 30 to 60% at 5 years or some longer period?
Okay, so for PTLD in kidney transplant recipients, it is about 20 to 30% incidence, and the survival rate is actually pretty good. The 30 to 60% mortality rate is generally seen in that first year after diagnosis. Once you've been through that first year, that mortality rate actually declines because you are controlling the PTLD. PTLD is actually its worst at its onset and kind of dwindles as you get therapy on board. So that mortality rate is highest. I actually am not familiar with the exact mortality rate like 5 years out. I could certainly look that up and make a note of that here and get back to you, Michelle, with an answer on that.
Okay.
So 5-year mortality rate. Sorry, I'm writing this down. Was there another question to that string that I've missed?
No, I think that was it. Charles, was that good?
Did she address the cure rate?
Cure rate. Let me look that up as well. And it's specific for kidney transplants, correct?
Yeah, that's correct. And also the 5 year, I just put that out there as an example. When you said cure rate, I didn't know for what period of time. So
sure.
You're actually saying it's at 1 year. So that's actually answering my question.
Okay. Okay. Perfect. I will look into this a little bit more. And if I find any other additional information specific to kidney transplant recipients about these questions, I will certainly send it to Michelle so she can send it to you.
Okay, that's great. Gwen is saying that she's 71 and she's due for her annual woman's exam. Don't think I get pap smears anymore. Should I consider it, considering the risk as a heart transplant patient?
So I think that's a really good question. So there is some guidance out there for your gynecologist to follow, and it's put out there by the American College of Gynecologists, and it is basically saying that if you've had a negative pap smear for 3 consecutive years, then you don't necessarily need to do a pap smear unless it's warranted. Now, if given you're a transplant recipient, it may be prudent to just periodically check that. So if it's been a little while since you've had a pap smear, there's no harm in asking for one, because as you said, your risk being a heart transplant recipient, and we know heart transplant recipients actually require more immunosuppression than other transplanted organs, it would be prudent to do that. But the fact that you've probably had negative pap smears beforehand indicate to us that you likely do not have HPV. So your risk of developing a cervical cancer is fairly low. So it would be okay to also not pursue it. But I think if you're interested and you would like to have that reassurance, it's a simple test that they do when they're already examining you. So you can certainly ask for it. And I would encourage you to do so for your own peace of mind.
I had some issues last year that involved my anal area. Let's
Mhm.
just put it that way, and an infection that actually caused my heart to reject.
Mhm.
You know? So I'm still having issues in that region. They're not
Yeah.
sure whether it's hemorrhoids.
Mhm.
I think they finally found out what it is. I developed degenerative disc disease,
Mhm.
which can affect your bowels, apparently,
Yes.
because I'm going through frequent bowels at this point. So
Okay.
Monday, I'm going in for the gynecologist. And,
Okay.
you know, I need somebody to tell me what's going on in that area.
Yeah.
Everything that I read about, my second doctor is Google. Everything I've been reading about DDD seems to dovetail with what I've gone through since October of last year.
Mhm.
Nobody has seemed to figure out what this is. They've had all kinds of, until the CAT scan happened, and now it's degenerative disc disease. Could it be
Mhm.
more? You know, because it does affect my anal area.
Yeah, and I think it's certainly reasonable in that case to get a pap smear done to make sure you don't have HPV. If you have HPV in the vaginal area, it is also high likelihood you have HPV in the anal area. It all just, unfortunately, that area all is affected by one another. And so I think in your case, it is reasonable to go ahead and get that pap smear and just make sure you don't have HPV and kind of put that out of the picture of possibilities.
Thank you.
Mhm.
Thank you. I think you've answered this. Is it necessary that we get skin cancer for sure after transplant? If yes, only skin cancer or other types? What type of precautions should we take to avoid? I think you've answered that quite a bit.
Yeah.
What is known about coronaviruses and cancer implications in transplant recipients? From
Good
Jessica.
question. Yeah, good question. So at this point in time, we don't know of any implications that coronavirus has in developing cancers. Coronaviruses have long existed before COVID-19, and those coronaviruses for sure are not oncogenic. We do not see any cancers related to coronaviruses. Whether or not the coronavirus that causes COVID-19 is slightly different, we don't know yet. But at this point in time, all preliminary information indicates that it's not an oncogenic virus.
Great, thank you. What about prostate cancer occurrence among lung transplant recipients?
So that is something that is quite possible. Lung cancer and prostate cancer are two things that I did not touch upon. They are not nearly as common as the cancers that I've talked about so far, but certainly something that is of occurrence. It does occur, and it is reasonable and very, I think, worthwhile to go ahead and get screened for prostate cancer because it does happen.
Thank you. If visual exam of anal area is normal, is anal pap smear still needed in transplant patient with HPV positive urethral cancer? And is nicotinamide, it's a drug, hopefully you can figure out what that is,
Yeah.
useful for prophylaxis for squamous. See, I could have never been a doctor. For squamous cell doctor. I mean, for squamous cell cancer. Sorry.
That's okay. So visual exam should be sufficient. I don't think an anal pap smear is absolutely necessary unless there's something abnormal that's being seen visually. We often do it for people who are with other HPV positive cancers. So it's not unreasonable to ask for, but it's also not absolutely necessary. So I think your doctor could go either way with you on that, and it would be acceptable. Nicotinamide, I'm not really too sure of how much literature there is on prophylaxis against squamous cell cancer with that. I can certainly look into that a little bit more. I personally have not recommended that for patients, but I can certainly look into it more and get back to Michelle with an answer for that too.
Okay, Barry, you'll have to let me know who you are. Let's see, in very general terms, how much higher a chance does a transplant recipient have of getting cancer?
So I think the longer you're on immunosuppression, the greater that cancer risk goes. So I would say, I think I mentioned early on, if at 10 years of immunosuppression, you're at about a 20% chance risk of getting cancer. So I would hope that's clear enough or general enough. If it's not, please let me know. I'm happy to try and give you a more specific answer.
Can you extrapolate to 20 years, 30 years?
So I don't have that data, but I can certainly get that data for you and give you an answer to, further out than 10 years.
Thank you.
Oftentimes, many of the studies that are done prospectively. So they get a cohort of transplant recipients and follow them forward in time. And most studies aren't generally done to 20, 30 years out, but I can look to see if there have been studies done to get that information. Sorry.
Excellent.
Thank-
Thank you.
Thank you. Are there foods or diets that are helpful to prevent melanoma?
Not that I'm aware of. It's all about, sun protective measures. So sunscreen, sun protective clothing. So clothing with UV rays, like UV ray protection if you're going to the beach or whatever. And then of course, getting routine skin exams. So those are the only measures that I know of to be able to prevent or detect melanoma early on.
Thank you. Can the COVID-19 virus cause cancers in the STO recipient?
So as far as we know, no. There is no, as I mentioned previously, the coronaviruses do not cause cancer as far as we know.
And then there's someone talking, and this is Charles, letting us know his PTLD arrived 10 years after his kidney transplant. And after 60 years of age, I was immediately taken off CellCept, placed on sirolimus. I've had 4 rounds of chemo. I'm currently in remission. Yay. It was speculated that my anti-rejection meds were at too high a level for too long a period. So
Yeah.
that's something you see commonly.
Yeah, yeah.
I'm a 70-year-old liver kidney transplant recipient and my infectious disease doctor wants me to get the HPV shot. I know it's more for younger patients. What are your thoughts on an older person getting the HPV shot?
I personally do not know of any literature out there to support giving it outside of the age groups for what it's recommended. Without having good evidence, whether it's FDA approved or not, but just literature and medical evidence out there to support a move like that, makes it a little bit challenging for me to support or endorse. I will take a look one more time in the literature. As to my knowledge, there is no literature out there about doing this, but I will take one more look in the literature and let you guys know if there is something out there that would potentially support this type of measure. But as far as there being a negative or adverse effect from getting a shot outside of the age group range is probably low, but I don't know what the effectiveness is. And that's where you have to kind of weigh the risks and benefits. There are all vaccines have some risk associated with them, whether you have a bad reaction to it or whatnot, but is the effectiveness or the effect of that vaccine going to outweigh that risk? And that's what I don't know. And I don't think there's literature out there to tell us what the effectiveness of this vaccine is in someone who's 70. But I can certainly take one more look and just see if there is anything out there that has come out in the recent times that, outside of the time that I've looked.
Do you still have time for more questions? Because there's
Yes.
still, okay, good, thank you. I have HPV, however, I have had a partial hysterectomy. Should I be concerned? Also, I have a wart issue on my hand and foot. What treatment should I be seeking? Nobody seems to be concerned so far.
So for the partial hysterectomy, if they leave your cervix intact and don't remove the cervix with the rest of the uterus, then you should have routine pap smears because you are still at risk of developing cervical cancer. If with that partial hysterectomy, they did take your cervix, then there is less concern for cervical cancer, but there still remains a concern for vaginal or vulvar cancer, in which case you should still be at least getting routine visual inspection by your gynecologist. Warts on your hands and feet, the best person to treat those is your dermatologist. They can easily freeze them off with like liquid nitrogen. It's a pretty painless procedure, and it's really easy to do. They can do it right in the office. So you should probably see a dermatologist to see if they can freeze off the warts.
Thank you. Is prostate cancer correlated with kidney transplant?
As far as I know, the group that tends to be more affected by prostate and lung cancers tend to be lung cancer or lung transplant recipients. So it's probably a little bit less than that group, but the exact number I don't know off the top of my head. But I can certainly see if there's literature out there telling me what the exact incidence is of prostate cancer in kidney transplant recipients.
I think this one should have gone directly to you. Are you available for ongoing fee-based consultation on medical related issues from Les Vi? So I don't know.
I
if
have
you
not
still
done
do
that. I have not done that previously in the past. You know, I think I'm happy to be available for questions just as is. You know, feel free. My email is at the end of the talk, and I will send my slides over to Michelle. So if there's any questions, you can always feel free to reach out to me, and I'm happy to try my best to at least give you some guidance on who to talk to further about things. But yeah, I appreciate that. But I'm happy to provide help just regularly.
Thank you. Is esophageal cancer common in heart transplant recipients? I was recently diagnosed with it.
It is not common unless it is HPV associated, which we do know HPV can cause esophageal cancer. So if it's not HPV associated, it is not that common to get, and it's you know, I'm sorry to hear of your diagnosis in general, but if it is HPV associated, it is much more likely that you got it because of that. And they can do testing on the specimen, the biopsy that they did, and they may have already done so to determine if it was HPV associated or not.
I think you answered this too. Other than skin cancer, any other cancer that may develop?
Yeah, so we talked about a lot of them.
Right. I'll send the slides out to everyone too. I know there were some people that came on like 20 minutes or so late, so maybe there's some information you didn't get, but the slides will be on the website. And then again, this is recorded, so this will be posted on our YouTube channel in about a week. So you can go back and revisit the beginning if you missed that. I had HCC and now have small lung tumor, too small to biopsy yet. Would this problem be met from the HCC or a new primary?
It's really hard to say. As transplant recipients, unfortunately, you are at risk for developing more than one type of cancer. So I think it's really hard to say without a biopsy. So unfortunately, it's going to have to likely be something that's monitored very closely with a CAT scan. And once it gets to of a size that can be biopsied safely, I think biopsying it, you know, when that happens is going to be most crucial. There is also the possibility that it may not be a tumor. Sometimes we can have lung growths that are not tumorous and that are not cancerous, that are just simply benign. But the only way to know is by monitoring it with serial CT scans of the lungs, making sure that the size does not increase. And when it does increase, or if it does increase, undergoing that biopsy is going to be crucial in determining what the cause of that nodule is.
Thank you. Anne is asking if I can share any of your research, that you respond back to me with everyone. And yes, I can. I will send whatever Dr. Seema sends me. I will then forward that on to everyone so you have that information. Is colon, stomach, or pancreatic cancer more common in transplant patients due to immunosuppressant?
So I would say colon cancer is probably more likely seen than stomach and pancreatic cancers. In general, even amongst the general population, stomach and pancreatic cancers are less commonly occurring than colon cancer. And I think transplant recipients kind of follow that same kind of picture. Though the incidence of cancer in general amongst transplant recipients is higher than that of the general population, but I don't believe stomach and pancreatic cancer in particular are of any increased risk. Colon could be potentially of increased risk, and we did kind of touch upon the scenarios in which colon cancer may be of higher risk.
Do you still have time?
Yes.
How does one avoid being overprescribed their immunosuppressants? What tests can be done for each individual aside from the standard guidelines?
So unfortunately, there's really no good way to avoid it. It's really dependent upon your physician and your overall clinical picture and trajectory since your transplant. So the more rejection episodes you've had, the less likely you are going to be able to come off or decrease immunosuppression. And when I say come off, I mean maybe taper off of like one of the drugs that you're receiving. And there's no good test to identify if you are overly immunosuppressed. If you are experiencing a lot of various viral infections, for example, if you are a kidney transplant recipient and you experience BK virus, that is a marker that you are too immunosuppressed. And the management for that infection or BK virus is to back off on immunosuppression. So there are like surrogate markers that we can use as physicians to determine if you are overly immunosuppressed, and that's primarily if you are experiencing a number of infectious issues. But there's unfortunately no magic test that we can use to really say, oh, this person has too much immunosuppression on board and this person doesn't have enough. So it's really your clinical picture and your physician's decision based on that clinical picture.
Thank you. You got hearts, big hearts in the eyes emoji from Joel and Judy because it's the most useful and informative webinar they've seen. Thank you for your comments. Any long-term studies you're aware of on long-term kidney transplants, general health at 45 years post? Well, that's a little off topic, but.
I do not know of any
Right.
studies that have followed, a cohort of patients 45 years out. I think we just generally know anecdotally how patients do. And I think if you're 45 years post-transplant, that is spectacular.
Remarkable.
Yeah.
Right.
Yeah.
Fabulous. And Les V, I'm sorry, I'm probably killing your name too. He echoes Joel's assessment of the webinar, and he thinks maybe we should have another session in 6 months. My heart transplant center does yearly chest x-rays to screen for lung cancer. Do you agree with this?
I think that is reasonable to do in a heart transplant recipient, as well as lung transplant recipients. It is one of those things that there is controversy about doing yearly scans of any sort, chest x-rays, CT scans, what have you, to look for lung cancer. But in these patient populations, heart transplant and lung transplant recipients, you tend to be at higher risk for developing these particular cancers. And so I think it is reasonable to do this. But of course, not all centers do this. And this is certainly weighed against the radiation exposure that you may have from yearly chest x-rays. But if your transplant center feels that this is appropriate, I don't disagree with it. I think it is actually quite reasonable to do.
Mm-hmm.
Thank you. Can you please expand on how mycophenolate could potentially reduce cancer risk?
So it's entirely dependent on the immunosuppressive drug mechanism of action. And I think it would be easier for me to write out exactly everything because it will entail a lot of medical terms that will likely need to be further explained. But it is entirely dependent upon the mechanism of action, the way mycophenolate actually works in your body, that reduces your likelihood of abnormal cell growth. And that abnormal cell growth is what ultimately leads to cancer that the other immunosuppressive drugs do that mycophenolate doesn't do. So I can write that out in an answer and share that so that it gives me an opportunity to really explain all the medical terms more clearly.
Thank you for an excellent webinar. Much gratitude to you for your time, expertise, and warm demeanor. We got a thank you also. Fantastic presentation. Thank you, thank you, thank you, thank you. Is skin cream that contains, I can't say that word,
Nicotinamide.
nicotinamide safe for transplant patients to use? Saw an ad for Olay Regenerist with this ingredient in it.
As to my knowledge, yes, nicotinamide is safe to use in transplant recipients. When I research the other question about nicotinamide and squamous cell cancers, I will also ensure of this information that I'm sharing with you to make sure that it is in fact safe to use. As far as I know from what I can recall of the literature out there, it is safe, but I will verify that and send that out as well.
Well, that is awesome. Thank you so much for all this extra time. Everyone always has some very specific questions, and I hope all of this has been helpful. And I will send out everything that Dr. Seema sends back to me. Please be patient. She's a busy woman. She does a lot of things, so might be a week or two before you get that email. I will send out the link to the YouTube channel so that you can revisit this presentation if you missed something, went to the restroom, etc.
And we'll talk to Dr. Seema about coming back in 6 months and redoing this lesson one more time. But
we're gonna have to, well, we don't have a payroll, but we're gonna have to create a payroll so that we can put Dr. Seema on it.
Dr. Seema, we want to thank you for handling our conversation today. It was greatly appreciated. We'd like to thank everyone in the audience this morning. We really appreciate you attending, and it's nice seeing all of you again. We want to remind you to check us out on our website at www.triomaryland.org. There's a lot of information on there, including all of our sessions that we've had over the last 2 years. And our sessions are also posted on our YouTube channel. We have a great Facebook and Twitter page, everyone. Please like us on Facebook. And I'm hoping that we're going to get to see some of you out at the Transplant Games of America in San Diego at the end of the month. So if you happen to be making that trip, please stop by and say hello. We will be out there. And we'd like to wish everyone a safe and happy summer, guys. So thank you for attending today. Dr. Seema, once again, thank you.
Dr. Seema, you're the best. Tell that husband to be looking for those opportunities back in Maryland.
Yes,
So,
I will. Thank you.
Okay.
I've had such a great time talking to you guys, and hopefully it was all useful information.
it was, you have so many kudos. You can go down the list. Everyone loved it. So thank you again for your time and expertise. And
Thank
everybody,
you.
hey, have a great Saturday. The rain maybe has stopped here, so enjoy.
Thank you, everyone.
Thank you.
Thank you.
Great
Bye-bye.
presentation.
Dr. Seema.